Let's talk about advanced hair loss and what to do if you're Norwood 6 or 7. This means that most of the hair in the DHT sensitive zone has been lost. What options do you have to look and feel your very best? Is FUE surgery even a possibility if you've already lost that much hair? And is it worth being on medical therapy if you've already lost that much hair? Let's start with some options that patients with advanced hair loss have. That includes doing nothing and pretty much accepting your appearance and just, whatever happens, happens. That's definitely the mentality that some people have, and that's totally fine if you're okay with that. Another option is to shave your entire head. And some people worry about the shape of their head. They sometimes will tell me, hey, you have a nice shape to your head, but I don't like the shape of my head, so I can't really rock that look. I think anyone can rock the bald look, but again, you have to be comfortable with that. Some people don't like shaving the back and the sides because it still looks like they have that kind of horseshoe appearance. And some will actually opt to do laser hair removal to get rid of each of those hairs. But then the problem is if you ever want to grow the hair out, well, now there's no hair left. Other options include covering up the area with, let's say, a wig, a hair piece, or a hair system. That works for some people, but that also carries a lot of cost, and some people don't like the feeling of just having something that is fake on their head, and then it affects things like swimming or, getting the area wet. And not everyone likes the look or the feel of something like a hairpiece on their head. There's even people who've had hairpieces for many, many years, even decades, and then they finally make a decision to rid themselves of that hairpiece, and that could mean just rocking the bald look, or they might be looking into hair restoration. Another option for covering up the area and giving it some sense of hair is with a scalp micropigmentation procedure. We have a video where we went into great lengths about what is SMP, how it's performed, and the pros and cons of it. Now, that look is great for some patients, but it's not really what everyone is looking for because, again, it's not real hair, it's just dots of ink that are meant to mimic the appearance of real hair. And then, of course, there's the option of a hair transplant. There are limitations to doing a hair transplant in an advanced hair loss situation, but let's delve deeper into some of those nuances. Now, it's important to go over the overall numbers of hairs that we're dealing with when it comes to the scalp. In an average type of situation, a person may have about 100,000 hairs on their heads. Now, this is at their prime when they're, let's say, late teenage years and they haven't yet, started to lose much hair. They may have 100,000 hairs, let's say on average. Now, that translates to about 50,000 grafts because each graft has approximately 2 hairs on average. Now, there are some ethnic differences here that I've highlighted in a past video, so make sure to check that out. Now, remember, there's the bald area, that's the DHT sensitive zone, and then there's the DHT resistant area, and that's the classic donor area. Now, about 75% of that 100,000 hairs actually lives in the classic recipient area, meaning that only 25% of your hairs are in the DHT resistant donor area. Now, in thinking about the number of grafts that are available in the donor area, it's important to then consider if we start with 50,000 grafts and about 25% are in the donor area, that gives us about 12,500 grafts in the donor zone. And we know that if you take an area that has a lot of hair and you deplete it by about 50%, that's when you start to see the thinness of the area. Now, going back to a donor zone that has about 12,500 grafts, if you take away 50% of that, that comes out to 6,250 grafts. So after harvesting about that many grafts, that area is going to start to look appreciably thinner. So that is the number, about 6,000 to 7,000 grafts that we have to give from the donor zone before it starts to look thinner, especially with FUE surgery. Now, we're not talking about harvesting that many grafts in a single surgery, but over the course of several procedures, let's say years apart, that's about how many grafts you can get before the area looks like it's been thinned out too much. So essentially, we're trying to use about 6,000 grafts to replace about 37,500 grafts that have been lost in that bald zone. The numbers just don't work. So why then do we even offer these procedures to patients? And why are most of my patients who start off as a Norwood 6 or 7 and get a hair transplant, why are they mostly happy? Let's find out. Well, it starts with managing expectations. It's important to give people a sense of numbers like we're talking about today and really inform them as to what they can expect, not just after a single surgery, but also after multiple surgeries, even if they're committed to that process. I don't want people expecting to look like they did when they were 18 if they're 50 years old and now in Norwood 7. That's not realistic. So my job is to give people realistic expectations that then they can decide, does the process make sense to them? Is it a good idea to invest, their time, energy, money into all of this if at the end of it all, they don't really end up with like that much density, right? To some people, that's a deal breaker. So I rather they know what to expect rather than be completely upset and disillusioned post-operatively. Now, when we're doing a hair transplant for a patient who is a Norwood 6 or 7, we're working with a conservative type of hairline. That's what we're building for the patient. We don't want the hairline to start too low because eventually we'll run out of grafts and then it will look even thinner. So it's important to keep that coverage tight, but to still give them the appearance of having some hair on their head because that's why they're doing the surgery. So if you're starting your hairline way too far back over that curvature of the forehead into the upper part of the scalp, well, now that might not make sense because when you look at them from a frontal view, you're not even necessarily seeing a hairline if it's starting too far back. So knowing where exactly to place that hairline and how to make it work with that hair laterally, that parietal scalp hair, that's an art form. And I've talked about that in how I design a hairline video. And that's something that you just have to have an eye for. And it has to make sense to us as the surgical team. It has to also make sense to the patient. For these cases, I generally do not do any temple work. So anytime someone has significant hair loss on their scalp and they're looking to refine some of the temple work, that usually doesn't make much sense because we know that temples can consume sometimes up to 300-400, grafts per side. And that's a big investment of grafts into an area that is not as critical as trying to rebuild some of these primary zones where the person may have lost hair. My approach for patients who present with loss at the frontal scalp, mid-scalp, and crown when there's complete loss is to start with a frontal scalp procedure. And that's what we're building up first. Usually anywhere from 2,500 to 3,000 grafts if we're doing, let's say, FUE or even FUT. That's a good start. That's a good solid procedure that's going to be safe for the donor area. It's going to leave them with good healing in the donor zone. And then we're going to be able to use those grafts to create something that overall looks nice at the frontal scalp. And then of course you need to have an overall strategy and be able to plan for future procedures and give patients a sense of what they're in for as far as surgery number 2 or potential surgery number 3. It's good to have that outline in advance so that again there are no major surprises and you're trying to control as many elements as you can because in surgery you can't always control every variable. So the things that are in our control we need to be able to modulate and again to be as upfront with patients as possible. So part of giving people an idea of what they can expect after a hair transplant, especially when they're starting off with a bare area, it's important to give a sense of potential densities. So when we're working on the frontal scalp and we're looking to do, let's say, a procedure of about 2,500 to 3,000 grafts, what is the expected density? Well, if we divide the zones into frontal scalp, mid-scalp, and crown, you're looking at 3 distinct areas. If the total number of grafts in those areas before you lost your hair was about, say, 37,500 grafts, right? Again, assuming 100,000 hairs as a starting point. Well, if you divide that number of grafts into the 3 zones, then your frontal scalp has approximately 12,500 grafts. So now we just do the math. What is 3,000 grafts out of the original 12,500 grafts? You're looking at about 25% of the original hair density. And at 25% density, there will still be that see-through appearance. And we've only worked on the frontal scalp. Now, what about those other zones, the mid-scalp and the crown? Now, let's say you've completed the first procedure to the frontal scalp. A year has gone by and you get the expected regrowth, about 25% of the original density, let's say. So now you're planning a second procedure. And if you plan on grafting the mid-scalp and the crown as a second surgery, well, now you're looking at 2 zones that you need to fill. And again, the potential density that you will create is going to be actually lower because instead of that one zone, that frontal scalp, you're now working into two separate zones. So you're looking at a potential density with the second surgery into the mid-scalp and crown of about 10 to 15%. Now, these are not percentages to necessarily brag about. So again, it's important to give people a sense of what they can expect when they're starting off with a fairly bare area. Now, keep in mind, these are just rough estimates, and of course, results will vary from individual to individual. It also has to do with the caliber of one's hair. So for the same number of grafts, if I have a patient who has a much thicker caliber of hair, well, their results are going to be much more impressive compared to a patient with that finer, wispier type of hair. So if someone is starting off with this Norwood 6-7 appearance and they're getting a procedure or even several procedures that's generating density that is not terribly impressive, how come they're happy post-operatively? Well, for one, though the hair appears thin, they still have hair in a place that previously had absolutely nothing. So again, if their expectations were appropriate, they usually end up quite pleased with their results. Many of these patients feel quite liberated and they actually stop wearing hats, whereas previously they walked around wearing hats everywhere. They feel like they can lose the hat, and that's a great feeling for many people. And for many of these patients, they've lived for decades now without hair, and they've kind of lost hope and they've completely given up, and now we're giving them a second chance. So many of them are extremely grateful, and it's surprising sometimes how many patients just get the frontal scalp done and they don't even come back necessarily for filling in hair further back because they're quite happy to just have hair from a frontal type of view. Now let's talk about choosing FUE versus FUT for a Norwood 6-7 patient. The nice thing about FUT surgery is that it could yield a greater number of grafts. So this could be for a single procedure or for the total yield over time over numerous surgeries. So usually it's about 10 to 15, maybe up to 20% more hair that you can capture from the donor area if you use the FUT technique, which is the strip technique. Also, you're harvesting from a zone that's highly resistant to DHT, whereas for FUE, you have to spread out over a larger area, and some of those grafts might be DHT sensitive. However, FUT surgery leaves that linear scar on the back of your head, and for many patients, they're looking to avoid that because you're essentially losing the option of being able to shave your head one day. And for patients who are bald in this zone, many of them end up eventually shaving their head. But if you have this long scar on the back of your head, well, you may not want to shave it because that's a highly visible type of scar when there's no hair hiding it. So for many patients, especially those who've waited decades for, FUE surgery to become more advanced, they don't want to even consider an FUT type of approach for harvesting the hair. So while I might offer them that because I know that the ultimate yield will be greater and I'll be able to do more at the recipient areas, they just don't want to hear about it. And that's, I would say, the majority of specifically men in that position with a Norwood 6-7 appearance. So even though it has some merits, many guys are still trying to avoid the FUT technique. And FUE surgery can still yield on average about 6,000 to 7,000 grafts over several procedures, maybe 3 to 4 procedures or sometimes more. And we can sometimes come in and do some body hair transplants as well to further augment the appearance of the recipient area density. Now, after the scalp has been exhausted, my next favorite place is going to be the neck region. And that's because that hair is most likely to regrow. It has the best chance of doing well at the recipient area compared to other donor areas such as like the arms, the legs, the back. Sometimes we might do some chest harvesting, but usually after the scalp is fairly exhausted, we might turn to the neck for the next best place for harvesting more grafts. Now, if someone's a Norwood 6 or 7, should they be on medical therapy? Now, some might argue, well, they've lost most of their hair, then what's the point of being on finasteride because, there's nothing else to protect or to preserve. You've lost it all, right? Or minoxidil, well, they just have hair back here. Why would you want to be on minoxidil, right? However, there actually is merit to potentially being on both. Most people who are Norwood 6 or 7 still have some of that fuzz in that frontal scalp, mid-scalp, and crown region, pigmentation. So you can amplify that fuzz and actually make it look reasonably better with the use of minoxidil to increase the thickness of each of those hairs. And finasteride can protect the DHT sensitive hairs in that horseshoe type of arrangement. Some percentage of those hairs are still DHT sensitive because we know that as people age and their hair loss progresses, that horseshoe tends to get a bit more short and it gets more narrow. And finasteride can help protect some of the DHT sensitive hairs in the donor zone because we know that especially with FUE, some of the hair that we're transplanting is going to be potentially prone to falling out because of the effect of androgens. So we want to secure that hair with finasteride, even for someone who doesn't have much hair in the recipient area to protect. And we have both minoxidil and finasteride available at feelconfident.com. That's where you can get the supply delivered to your door if you qualify. So make sure to head to feelconfident.com and fill out the questionnaire. And some patients after a hair transplant decide to get scalp micropigmentation or camouflage fibers to give the appearance of improved density. At the end of the day, managing advanced hair loss comes down to managing expectations and letting people know what is truly possible and what isn't.